Okay, thanks everybody for waiting. We will go ahead and get started. Thank you everybody for joining us. Welcome to the latest Duke media briefing on the COVID-19 pandemic. I'm Gregory Phillips with Duke Communications. Mask mandates are being rolled back across the US, placing more responsibility for managing COVID risk on individuals, just as new variants of the virus are causing disease outbreaks across the world and in some cities here in the US. We have two Duke experts with us today to discuss navigating this latest phase of the pandemic. With us this morning is David Montefiore. He is a professor and director of the Laboratory for AIDS Vaccine Research and Development at the Duke University Medical Center, where he has been studying the emerging strains of COVID-19. Also joining us is 𝐿𝐴𝐚 𝐁𝐫𝐢𝐚. He is an infectious disease specialist at Duke Health and an associate professor at the School of Medicine, where he studies infectious diseases and biological and emergency preparedness for hospital systems. Good morning to you both.
Good morning, Greg.
Dr. Montefiore, we'll start with you. There are signs the BA2 subvariant is spreading in the US. What do we know about it, and how much do we know about the likelihood it could cause a surge in cases beyond the areas where numbers are already up?
Yeah, so there are several forms of the BA2 sublineage now that are apparent and showing some signs of spread. And one of them in particular, called BA2.12.1, is really starting to take off in the United States and other parts of the world. And it's becoming the dominant variant in certain places in the United States, like New York City. And so far, what we know about this new form of the BA2 sublineage is that it doesn't appear to cause any more severe disease than the earlier forms of Omicron or other variants. And what we're really interested in the most right now is, does it pose a greater threat to the vaccines? Is it going to be more of an escape variant than the initial BA1 form of Omicron?
Absolutely, thank you. And obviously there'll be a lot more to say about variants. Dr. Wolf, I'd like to come back to you. With the latest variant and the current case trends, to what extent are you bracing for another surge? And how are hospitals viewing the current situation with cases in the US?
Yeah, it's a good question, Greg, and I appreciate the chance to join everyone. Look, I think there's one of the things that we began to see with Omicron in sort of earlier strains and continue to see, I think it speaks to David's point about severity, is a little bit of an increasing divergence as we've gone between infectivity, ease of transmissibility, and hospitalizations. And I think locally for us in North Carolina, we have not seen, reassuringly, any significant jump in the numbers of hospitalized patients yet. That said, in some of our European colleagues, for example, who were a step ahead of us in some of the BA2 variant emerging in their areas, they did see an increase in hospitalization, although not to the same extent as they did for previous variants. So we've learned a lot more over the last couple of years, I would say, in terms of how to handle surges of patients should they come. Although I think internally we remain much more optimistic about these variants compared to previous ones, given good vaccination rates now in our community, decent adaptation within hospitals of how to handle them, and no signal that I know of, and it sounds like, David, you're of the same opinion, of sort of severity indicators or mutations at severity points that sort of trigger our alarm, knock on wood. So we're sort of certainly observing the data. I think we have our staffing models in a place now that allow us to flex if we saw an incoming surge, but so far so good.
Sure, absolutely. Thanks to you both. Dr. Montefiore, coming back to you, you talked a little bit about the BA2 subvariants here. What do we know at this point about how contagious they are, and compared to Omicron, previous variants that we've had? And do they give us any clues as to what we can expect in terms of contagion from future variants, or is that more random?
Yeah, so we have seen multiple waves of variants, and starting with the Alpha, and then we had Delta, and now Omicron. And each time these variants acquired a higher degree of transmissibility. And I think we are maybe starting to see a tipping point where the virus is continuing to become more contagious. This new BA2 is more contagious than BA1. The BA2.12.1 appears to be a little more contagious than the original BA2. But at some point, I think the virus is going to reach a tipping point where it's just not going to be able to acquire any greater improvement in transmissibility. When we'll reach that point is really difficult to say. But we are seeing that the virus is continuing to be able to evolve and become more contagious. Now, that said, the good news is that these variants do not appear to be any more pathogenic. They are not causing more severe disease. That's a good thing. And as far as we can tell, the vaccines are still very effective against all of the variants. It's very important to know that you need to get boosted for protection against the Omicron variants. But with the boost, the vaccines are still holding up very well. And hopefully the virus will not be able to find a way eventually to evade our vaccines. And that's just an unknown question at this point.
Sure, absolutely. Thank you. And before we move on from that point, you brought up the notion of boosters. And one question that we had asked if all over 50 should get a second booster, a fourth shot, and whether there's any benefit that we know of to getting a different booster to the original shot that you had.
Well, those are really good questions. And I get asked those questions all the time. And in part, it depends on who you are and what your health status is, what age you are. Do you have any underlying conditions, immunosuppression that would predispose you to more severe illness and that would require additional boosting to really mount a strong immune response to the virus? Those factors weigh in to the decision of whether or not you need a second booster. I think at some point, everybody probably will want to get a second booster. But how long that is really unclear now. And that's because of waning immunity. And it's really important to monitor waning immunity in terms of immunity against severe illness, hospitalization, and death. And it's just going to take time to acquire enough data to really have good answers to when these boosts are going to be needed. Now, and what will the boost be? Several companies have already developed Omicron versions of their vaccines. These are bivalent vaccines, so they have the Omicron spike in them as well as the original Wuhan spike in them, so that hopefully that will give broader protection. And I know, for example, Moderna is actually hoping to have that boost ready for the fall, if in fact there's evidence that the bivalent Wuhan Omicron boost would be advantageous at that time.
Absolutely, thank you, Dr. Wolf. Oh, sorry, go ahead. Did you have?
I might just build on that a little bit. If
Please.
David mentioned some really important points there in terms of individual health status as helping you to sort of stratify whether you should get boosted. I would add to that it's your individual activity and how you perceive your risk exposure weighs into that too. So I can now, I think, affordably have conversations with people who have impending travel, for example, and say, look, hey, if you know unavoidably you're going to have a higher exposure potentially, then this may be the right time to boost. Similarly, if folks have, maybe their own health status is okay, but they don't want to be the vector to inadvertently bring COVID into a family situation with elderly grandparents or transplanted patients, then maybe their boost at this stage is the right time. So I think it's both an assessment of the individual's health status and also, frankly, what their risk is. And we're sort of entering a situation where I think there's a bit of flexibility to that. At that point, we're talking about a second booster on top of already presumably 3 doses that person's had. There's a bit of sort of, you can individualize the conversation very effectively.
Sure, absolutely. And I'm glad that you brought that up because, how individuals manage risk seems to have become a more important question now because a lot of mandates have been rolled back. And you mentioned air travel, and we've had a number of questions about this. So putting aside, whatever political factors may have factored into mandates, with mandates being removed and individuals having to make the call, if somebody is faced with a situation in which they say have to travel internationally, would you advise individuals, yes, you should mask on a plane, or is it more nuanced than that? What kind of conversations would you have with somebody who was traveling internationally and wanted to do everything that was reasonable to be safe?
Yeah, it's a really tricky question and an important one to raise. I mean, I'm not a legal scholar, so I don't pretend to want to get into those discussions other than saying I always find it complicated, to be diplomatic, when public health guidelines fall into the foray of sort of legal disputes. I'm not sure that's a place we ever want to really get to. But that being said, the first thing to say is if you're flying internationally, be very careful because the international rules on your carrier may be entirely different than what's applicable in the United States. So, for example, I was recently able to go back to Australia and my rules were defined by Qantas, the Australian carrier, not by my US colleagues. So I think being aware of the jurisdictional rules in the place where you wish to travel is first and foremost a crucial rule. I think in terms of risk, there was a lot researched early on in the pandemic to show that, in fact, the sort of contour of airflow on planes was very effective in reducing COVID risk. But I think it's a misnomer to assume that that risk is zero. When we've also had data now sort of cemented to say that the risk is not zero if, for example, the person next to you is positive. And equally, there's clear data to say that masks are bidirectional in their effect. So I don't change my message in light of this week's sort of federal mandate changes to my immune suppressed patients to say your best protection as an individual is still to wear your mask. That's something you can control, particularly on longer flights or sort of times when you're not in a controlled situation. But similarly, I do think we have to acknowledge it increases the risk of transmission events if the person beside you no longer has any layer of protection that shields viral spread. I may have lost you here on this. There we go. Sorry, my screen went still. There is increased transmission risk in that situation. Is it low enough in the current setting of relatively quiet transmission to take away a mandate? That's a political question at that point. But I certainly counsel patients to say, look, you need to assume that public transport risk is not zero. I think the other thing that's really tricky about this decision and the timing of it is that when we are encouraging people to make individual decisions about health risk, and that's appropriate as we move into a chronic phase of this pandemic. I can make an individual choice to go to a restaurant, for example, if that restaurant is unmasked and non-mitigated. Many people don't have the choice to take public transport to work. And I think in situations in particular, that's often disproportionately affecting lower socioeconomic families who come from racial backgrounds where COVID has had a more substantive impact. And there's a lot of people in our community who, in fact, cannot avoid. We think about planes. Planes are a bit of a luxury. I also think of metro and buses and trains as means of public transport that these rules impact. And for those individuals, I think there's still pretty compelling reasons why they should think carefully about masks.
Sure, absolutely. Thank you. Just like to remind everybody that we are open to questions. Thanks to everyone who submitted questions in advance. We certainly have plenty to carry us through. But you can also post questions via the Q&A window at any time. If you would like to ask a question in person, raise your hand in Zoom and we'll unmute you when your turn comes around. And if you're calling in by phone, you can raise your hand by pressing *9. Dr. Montefiore, to come back to you and the current slate of subvariants that we're dealing with. Do we know at this point how effective the tests that are in circulation are at detecting this variant, and how important is it that they're able to detect that variant in particular?
Yeah, well, fortunately, the tests aren't affected very much by the variants. They are based on multiple portions of the virus. And the portion of the virus that we're most concerned about for vaccines, of course, is the spike protein, because that's what's in the vaccines. And that's what antibodies are directed to that block the virus from infecting cells. But the tests are based on other proteins of the virus as well that aren't as affected as much by the mutations that are occurring in these variants. So, so far the tests, for the most part, are still very effective with all of these variants and subvariants of the virus.
Sure, absolutely. Thank you. And staying with you for a second, and Dr. Wolf, feel free to weigh in on this too. Obviously, we've seen that testing on a large scale is much smaller than it was a few months ago at the peak. Does that mean that how much trust can we place in the public numbers of case counts when, if people are testing at home, those aren't necessarily reflected and there are just less tests happening entirely? What kind of metrics should we be looking at for a true example of where we are with cases?
David, I don't know if you want to go first on that one.
I'll let you go first, Cam.
Okay. I mean, it's a wise question, because I think you have to concede that the numbers are a significant underestimate of the actual burden of COVID that's in the community. Look, but that's always been the case. I think there's always been testing variability across many states and jurisdictions throughout the last 2 years. And so we've always tried here to have a sort of multiple view of how COVID would impact a community as we understand what its risks are. And this is actually reflected in CDC data at the moment. So for example, the CDC, when they look at a county and talk about impact, they look at three things. They look at the rate per 100,000 of infection, and obviously that's biased by how often you do the tests. But to accommodate that underreporting, they also look at hospitalization, and they also look at proportions of hospital proportions of hospital beds taken up by COVID patients. Like, how much is the current wave impacting your ability to deliver healthcare? That's an impactful endpoint. And irrespective of how many tests you do, our hospital line in the sand as to how sick you need to be to come into the hospital has really not changed. And so hospitalization has always been a fairly fixed endpoint and measure of how much impact COVID is having on a community, which is unrelated to how often you deploy the tests. If people get sick enough, whether they're tested or not, they'll end up in the hospital. The other group who I think is really helpful is employee bases. You know, we're still in a situation where, for example, us as a major university or healthcare system, we require our staff to tell us when they're sick. And we notice that rates are going up in the last 3 or 4 weeks, even though many of those tests are done on home rapid tests where they don't get fed in automatically to public reporting systems. And yet we see those trend lines drift. Private institutions will see those trend lines drift. Employers will see those trend lines drift. We saw in Europe, airlines, for example, saw their numbers of employees who were out of work increase as variants flowed and merged. And I think those sort of endpoints actually become really good measures to say, look, here's the burden of disease, but then also when we look at the hospital, here's the impact of that burden, and therefore what can we do about it?
Sure, absolutely. Thank you. Dr. Montefiore, we had another question regarding the variants. It says with BA2 and now BA2.12.1, does it look like future variants will arise from Omicron? And if that is the prediction, what does that mean for how we handle infections going forward? Does it make it more likely an Omicron-specific vaccine will be successful if and when we get one? And do we have any sense if the disease will get less severe as Omicron continues to evolve?
Yeah, very good questions. And we really don't have answers to those questions, unfortunately. We have seen subvariants of the other variants, for example, Delta. There were multiple sublineages of Delta that were part of that wave. So what we're seeing with Omicron isn't really much different from what we saw with other earlier variants, except that in the case of Omicron, we are seeing these new forms be acquiring increased transmissibility and outcompeting the earlier forms. So maybe that is a sign that we will continue to have Omicron lineages that will continue to evolve and hopefully not be able to evade the vaccines. But it's really not clear. We haven't seen so far in this pandemic the different variants of concern really arising from one another. They've been independent forms of the virus, especially Omicron. not really related to any of the earlier variants. So, are we transitioning now to a different stage in the pandemic where Omicron is going to be with us for a while and that is going to continue to evolve? Or will we see the emergence of yet another unique variant that will become more contagious and become the dominant variant? We just don't know. Overall, a new variant of concern has emerged that has become the dominant variant in the world every 4 to 6 months. So I think, we're just going to have to wait and see what happens this time. It's very different now because you have so much population immunity built up that could really impact how much the virus will continue to change.
Sure, absolutely. And staying on the this topic of the evolution of the virus, we had a question come into the Q&A asking whether these, or to the extent to which these new variants threaten our chances of ever reaching an endemic phase with the disease.
Well, will the virus evolve and escape the vaccines? That's really the big question right now. I think we're on a trajectory where this pandemic is becoming endemic. I think this virus is always going to be with us. It's something we're going to have to learn to live with. And the hope all along was that at some point there would be enough population immunity built up that this would become a common cold for most people, or no worse than the flu in terms of the number of really serious cases and deaths. And we seem to be moving in that direction. And more time is needed to really know for sure whether or not waning immunity is how much of a problem is that going to be, and when will people need to get boosted, and what will they need to be boosted with in order to maintain the level of protection that's needed to keep it endemic. And will the virus eventually find a way to escape our vaccines? Scientists generally agree that in comparison to flu, that so far all of the variants that we've seen of SARS-CoV-2 really belong to a single serotype. We haven't seen it evolve in a way that has really escaped the immunity that people have built up from the vaccines and from infection. So there's still a risk that at some point in time that could happen, that it is going to drift and evade all of the immunity that's built up in the world's population. But this is a coronavirus. Coronaviruses aren't as adept at escaping as the flu viruses, for example, but with enough time, it's possible that it will. And that the vaccines, it'll be even more important that the vaccines change to keep up with that new variant, should a variant emerge that does effectively escape our vaccines.
Sure, absolutely. Thank you. Dr. Wolf, did you want to weigh in on that too? It looked like you were.
Yeah, I think the question of endemic activity is sometimes interpreted in different ways. I think there's the sort of the virologic interpretation of endemic, which I agree with David, we're approaching, and we should expect that this virus will be with us in various forms hereforth. But I think endemic has sometimes been misconstrued in the public discourse to mean sort of, when do we go back to being normal in our levels of activity? And that is perceived as the point of endemic arising. And that we're getting very close to as well. When we were in Omicron, we still had hospital shortages. We had patients who were being diverted. We had activity that was curtailed. We had lots of public transport, restaurants, activities that were not being able to be performed because of the impact of the virus on our community. Whereas I think what you've seen in the last few months is that you've seen our response from a public health standpoint return to a much more sort of, hey, this is being managed but like a regular respiratory illness. It's not derailing our day-to-day activities. We don't see mass school closures. We're trying to accommodate the virus, sort of coexist with COVID, if you will. And that sort of social endemic response, I think, is what is often perceived by people to be the endpoint. And we're approaching that too.
Sure, thank you. And on a similar topic, Dr. 𝐊𝐿𝐿𝐼𝐚, I'll come back to you, and Dr. Wolf, I want to hear from you on this as well. From the start of the pandemic, the stated goal, one of the stated goals for public health leadership was reaching herd immunity. But now we're seeing reinfections, people sometimes who are vaccinated and boosted getting COVID again. Does that mean that herd immunity is no longer a goal or not realistic? And if so, kind of how does that change the game and how we approach it, or how concerned should we be if herd immunity is no longer something we can strive for?
Well, I think we're seeing a really major impact of herd immunity on the pandemic. Not so much in terms of reinfections, but in terms of disease severity and deaths. They're going down remarkably, and even in during the Omicron wave, we had this huge spike in infections, but we did not see the corresponding increase in severe illness and deaths that you would have expected from a spike that high. So this is evidence that pre-existing immunity is having a major impact on the pandemic in terms of preventing serious illness and deaths. And I think it can be improved and needs to be improved if more people would get boosted. That's a very strong message that I like to send. Not enough people have been boosted. We were very fortunate during the Delta wave that preceded Omicron that the CDC recommended that people get boosted. And that was controversial at the time as far as whether or not a boost was really needed for Delta, but it was fortuitous because people were getting boosted, and the boost is really needed for Omicron. And so we, got a head start in terms of getting people boosted even before Omicron came on the scene. But here we are now, months later, and we still have at least half the people in the United States who are eligible for a booster shot that haven't received one. And I can't emphasize enough how important it really is to get boosted for Omicron. There's no question about the need for the boost now to protect against serious illness and death in the case of Omicron infection.
Absolutely, thank you. Dr. Wolf, we've had a number of questions come in about wastewater sampling. This is one of the ways that obviously communities can monitor for COVID cases. Can you explain a little bit about why that's important, and whether, because we're seeing that the numbers are going up in North Carolina, is that something that you are concerned about?
Yeah, so wastewater sampling is a technique that relies on the fact that whether you know you have COVID or not, whether you're particularly symptomatic or get a test, we shed COVID particles in our stool. And so you don't need much to actually find a positive. So in fact, you can collate wastewater collection points across a community, across a college, or across a town, and sample and see how many positive hits you get. So it becomes a sort of a community-wide screening of activity that helps you sort of look at a rate of COVID in that area. It doesn't pick out an individual person, like we don't sort of sample individual toilets, but we sample major collection points. And I think it helps because it gives you another guidance point for overall trends. Perhaps because of test availability in a certain area, people are not presenting their positive information or not reporting their symptoms to public health. And so this becomes a surrogate way of finding out how much disease is in that area. I think there's also a molecular assistance and a genetic assistance in doing this, because it gives us more samples that are spreading in that community at the moment to sequence and understand what variants are moving through a different community, even if those samples are not delivered to us sort of in person through a regular swab. So it helps both from a sort of community disease surveillance perspective, but also from a virologic perspective. Now, the challenge is that, of course, it's not evenly distributed across the country, and many jurisdictions are still sort of rolling out efforts to try and collect wastewater in that way. There's a certain aesthetic that, to be honest, is still difficult about getting it done. But it certainly gives us a visibility that I think will continue to be helpful as we look forward.
Absolutely. Thank you very much. Dr. Wolf, coming back to you, we've had another question come in regarding variants. It says that we've accepted the idea, it seems, that Omicron is somehow more mild than prior variants, But is it really more mild as a pathogen, or does it cause less severe disease because of the immunity that you've talked about that we've built up as a community? Could we see more severe disease from Omicron variants as immunity begins to wane?
Yeah, I think that's a good question. And it's sort of, it's maybe put in two parts. I mean, I think the answer to the first part is it's both a viral phenomena and an immunity phenomena. So, we weren't necessarily clear on that early on as we saw Omicron emerge in South Africa. We weren't sure if this was just because South Africa had such a heavy sort of amount of natural immunity from prior variants. But what was clear as we moved further through is even when you compared Omicron in an unvaccinated and previously non-infected population against Delta in an unvaccinated and previously infected group, the Omicron case was more mild. Add to that, all that we've talked about so far is that your likelihood of getting a more mild case is all the much better if you've also had a vaccine. They clearly work together. The second part of the question I think remains important though, and that's, can we see a future evolution of a variant that either escapes or gets around our immunity to a greater extent, or that sort of as our own immunity wanes over time, getting back to the booster comment, does Omicron naturally sort of become more severe for us as an individual? And I think the answer to that is yes, that may occur from a viral evolution point of view. We don't know if or when, but for sure, as our own natural immunity occurs, the risk of a severe disease goes up. And that's why you see public health groups, for example, targeting older adults. We know older adults naturally lose their immunity over time a little quicker than someone who's young and 25. So we'll target giving them a boost and propping up their immunity more soon because we want to avoid that potential for severe outcomes. So it's a really good question, and yet it's clearly a viral factor, it's clearly a host factor, and it's clearly a time factor. How long have you been since you got your boost?
Sure, Dr. Montefiore, anything to add to that?
Yeah, I would agree with everything Dr. Wolf just said. And, in terms of studying this in the human population, it's getting more and more difficult because of so many people having prior infection or being vaccinated. And in many cases, people who experienced prior infection and didn't know it and could be, jeopardizing the integrity of the data in those types of human studies. But people have also been looking at the pathogenesis of these variants in animal models. And interestingly, what they found is that the Omicron variants don't appear to be as pathogenic in animal models as earlier variants are. Now, whether or not that's an indication of the situation in people, there's always that caveat. But it is interesting that they do appear to be somewhat less severe in these test animals that the variants have been tested in.
Sure, thank you. And Dr. Montefiore, staying with you for a moment, we had another question about vaccines, and it asks that given how short the booster effectiveness lasts, looking at the recent Israel study, if someone over 65 chooses to wait to get a fourth shot until, for example, they decide to travel, would that mean they wouldn't be able to get a shot in the fall if a new vaccine is ready then?
Yeah, that's a good question. If you've been boosted, I wouldn't think that you would need, based on the current data, looking at protection from serious illness and death, at least, that protection is holding up for a longer period of time than the antibody titers are. And the antibody titers, neutralizing antibody titers in particular, are often used to gauge how long immunity is lasting. And they are predictive to a certain extent. But not entirely predictive of protection against serious illness and death. So we really don't have good answers to the question of when to be boosted, what to be boosted with. And that's a very good question. Would it preclude you from getting boosted in the fall, for example, with a variant vaccine if you got boosted now or in the next month or two? I don't think anybody really has any clear answer to that question. And, certainly I'm not aware of any data that would address that question. There is some concern that boosting with a variant vaccine will be less effective, that the response to the variant will be less effective because of all of the prior immunity that you have to the initial vaccine, that may dampen the response to a variant vaccine. And those clinical studies are going on right now to test whether or not that in fact will be an issue for variant vaccines. I've seen some early data that boosting once in people who've already received 3 inoculations of an mRNA vaccine, for example, boosting once with a variant vaccine does seem to improve the response against all variants. It's not a major improvement, but it's certainly not inferior to the response that you see with the original boosting, again with the original vaccine. And what will happen if you've received 2 boosts of a variant vaccine is another very important question. And there just aren't any data right now. Those studies are just starting now.
We got a little hint of that, didn't we, when Moderna talked about their bivalent beta and Wuhan variant? It looked like it was broadly supportive of that approach, although that's preliminary press release data, to be fair.
Right. And they'll have similar data for their bivalent Wuhan Omicron vaccine later in the year, probably by early summer.
Sure. Thank you both. Dr. Wolf, based on your hospital experience, we've heard the encouraging news that there hasn't been the same kind of spike in hospitalizations that we saw with Omicron or with Delta. But now we've got more data on treatments. How effective have you seen the antiviral pills and antibody infusion treatments being for patients? And is there anything else on the horizon that people should know about?
Yeah, I think they've really made a big impact. I probably carve that answer into 2 folds. One is the people who are symptomatic and yet not yet severe enough to be in hospital. And I think that's the optimal time when we still want to reach people. In that group, antibody infusions, or particularly the pill called Paxlovid, have had, I think, a really positive impact on preventing the severe inflammatory pneumonias that we saw in 2020 and 2021. There's a timing to that. You've got to get them to people quick enough to make a difference. And there's some lack of clarity in terms of how they really help in a vaccinated population. They were studied in unvaccinated individuals where, of course, the risk of hospitalization was that much higher. And they were traditionally treatments studied in a non-Omicron era. So if you add the less severe Omicron variant and the benefits that vaccination have already afforded you, we get into a more nuanced conversations with patients who have minor symptoms, but in all likelihood will not be going to hospital anyway, to say, look, hey, how much do we think this treatment really helps? But it's certainly, they're safe, they're available, they're widely disseminated now across the country, and people should be aware of them. The inpatient treatment remains complex. By the time people need the hospital for their COVID specifically, they're usually in a very inflamed state. Their body's response to COVID has been so dysregulated that they need strong anti-inflammatories, either intravenous steroids, intravenous antivirals, or in fact, more heavy gun immunosuppression to try and calm down their immune system. And there are some people who we don't successfully treat in that situation still. If I look at our hospital census at the moment, we still have people who, particularly amongst our elderly or immunosuppressed, who may not have had the chance to mount a sufficient positive response to their vaccine, that they still get a really dysregulated immune response. They still get severe pneumonia. Some of those patients are still sadly dying. They die at less rates than they did originally, because I think we're getting better at managing them for many reasons, but we're a long way from being perfect there. So clearly the better intervention point is before someone ever gets sick enough to need the hospital.
Sure, absolutely. Thank you. And staying on the kind of patient focus thing here, we've had a number of questions, and anecdotally, people finding that they get COVID, they're symptomatic, they remain at home, and then after a period of time, they test negative, but they're still having some lingering, chesty cough symptoms. And people are wondering, like, if they're testing negative, but still a bit symptomatic, how should they think about going back to normal, returning to work? Because sometimes, obviously, people want to stay away from places if they're sick, But if they have a lingering cough or lingering chesty symptoms for weeks at a time, at what point, can people think about kind of returning to whatever passes for normal? And I realize those are individual decisions, but I guess some of the things that people can bear in mind when they're trying to make those kind of decisions.
No, it's a great question. And I think, lots of people have lingering symptoms. That's one of the real challenges of COVID, is particularly a post-viral cough, which we see for lots of other illnesses, can be very common here. The fatigue is quite common. A third of patients will report a month down the road that they're still quite fatigued. So the reassuring part of that, though, is, the tests not only are quite good at determining the sort of the volume of virus that you're shedding, which translates roughly into your infectiousness to people around you, if you will. But that when we've done the more complicated, laborious studies to try and sample people sequentially through their illness and find how long they continue to shed viable virus for, in fact, those are usually quite short. So even though people often have symptoms that are more protracted than, say, 7 to 10 days, in fact, their likelihood of having viable virus beyond that point is incredibly small, which leads to all the public health decisions then to say, we don't need isolation for infected people longer than the sort of 7 to 10 day window, 5 to 10 day, in fact, that you now see in the public space. Even in the people who are the most sick, so immunosuppressed patients who don't respond well, people sick enough to be in the hospital, we feel very comfortable after a 20-day window that they pose us as their healthcare workers no substantial risk at all, and we take them out of their isolation. Not to say that they have recovered from all of their symptoms, which can persist for a long time. And that kind of then comes down to a decision like it does when we get flu. Lots of us have persistent post-viral cough for many respiratory illnesses, and this is going to be the same thing. But there's that difficult conversation, isn't there, with what, like, if your work colleagues know you had COVID, sort of, hey, I've gone through my isolation period. Yes, I may still have a cough, but it's no longer really persistent. The other part of that is, I think it's entirely appropriate for people as they recover out of that, as they start to head back to work, to use that as an early time to have a mask. In fact, we see that as part of the guidelines that from day sort of 6 to 10, you can return to activity in a mask situation. And I think that not only is the right medical thing to do in case you're one of the rare people who remains infectious in that 5 to 10 day window, but it also offers, frankly, comfort to the people around you because they feel more reassured that they're not going to get sick.
Sure, absolutely. Thank you. And I appreciate you returning to the topic of masking. Dr. Montefiore, we've had some questions about, obviously now we have more data regarding masking. How much more do we know than we used to know about the difference of effectiveness of different kinds of masks? Some people say that cloth masks are completely useless and you should always go with something surgical. But I mean, what kind of feedback can you offer people in those situations? Is a cloth mask better than nothing at all, or should people be looking more at your more surgical options?
Well, any mask is better than nothing at all. But I think the message was very late coming out that the most effective masks are the N95s and the KN95 masks. They're far better than the surgical masks and just wearing a cloth mask. And it would have been helpful if that message got out to people sooner, and more people were using those masks. They're far better than any cloth mask and even the surgical masks are.
Sure, absolutely. Thank you. And staying with you for a moment, you've both mentioned bivalence, and we've had a couple of questions, people asking exactly what that means in this context.
So by bivalent, I mean that the vaccine now has 2 different variants of the viral spike protein in it. So the one that Dr. Wolf mentioned earlier, he called Wuhan and beta, that was what was described in a press release from Moderna just earlier this week. That vaccine has the spike protein of both the Wuhan, which is what is in the initial vaccine, in the vaccine that's used now. And in addition, it has mRNA that encodes the spike protein of the beta variant. And now Moderna and other companies are working on a bivalent vaccine that again has the original Wuhan spike in it, but in addition, it has the Omicron spike in it. So these are called bivalent vaccines because they have 2 different spikes in them.
It's one of the real advantages, I think, of the mRNA technique is that you really get a chance to put a lot of different opportunities into the same vaccine. We're used to that with flu. We have quadrivalent vaccines for flu. The sort of the holy grail there would be that you combine flu with RSV, for example, respiratory syncytial virus, with COVID, and could modify that as we go along. And I think you're starting to see the early evolution of that trend.
Sure, absolutely. Thank you both. Dr. Montefiore, we just had another question coming about boosters. It says, if someone has just had COVID, should they get a second booster immediately or as quickly as they can?
Well, if they were previously vaccinated and then they experienced infection, they have what we call hybrid immunity, which is very potent immunity. The combination of infection and vaccination, either way, whether you got vaccinated after you were infected or you got infected after vaccination, tends to induce a very potent immune response. But I would still recommend getting boosted after you recover from infection. You probably don't need to get boosted right away. That almost serves as a boost. But over time, even that immunity is going to wane, and another boost would be a good idea. But it's really difficult to say right now how long you can wait before getting that extra boost. Certainly, you would not need it necessarily right away. You could wait some time, and right now people are interested in waiting for the fall and see what's available. If Omicron continues to stay with us and we see these minor variants evolving, but it's still essentially Omicron in the fall, then it might make sense to get boosted with a vaccine that has the Omicron spike in it. And should you wait for that or get boosted sooner with what's available now? Really good question, and no clear answers, because the immunity that you get from infection on top of vaccination, yes, it tends to be very good, but how long it lasts and when would you eventually need a boost? There's really no clear answer to that question. But the bottom line is infection on top of vaccination, or the other way around, in vaccination in a person who's previously infected does tend to generate stronger immunity than either infection or vaccination alone.
Sure, absolutely. Thank you. And appreciate everybody sending in questions. We're going to barrel through as many of these as we can in these last few minutes. Dr. Wolf, one thing that people are asking is that right now, as you said, there's lots of encouraging news and people out in public spaces are going about their business. What kind of benchmarks should we look at for any indication that perhaps when going to the store or out in public spaces that it might be time to be more careful, more distance, more masking? Are there particular indicators that people could look to?
Yeah, it's a perfect question. Look, the rate of infection is number one. That will be an underestimate, but it's certainly, you see trend lines that are drifting. And if we were seeing a trend line going up with the presence of a new variant, that would give me a pause. I think what the CDC has now made visible to people is a very helpful tool where you can go to your individual county and say, am I in a green, yellow, or red concerning area based on rate of infection, but impact on healthcare and impact on hospitals. And that to me is a beautiful tool that we can all now use, and we do use with our public health colleagues. I think beyond that, the other thing, honestly, is look around your community. We saw in Omicron how much it hit our community in terms of school closures, plane closures, flights canceled, buses not working, the postal service not ticking along. Like, we got a really quick insight as to how many people were sick by simply looking at how operationally things were deficient in our towns. And I think that becomes a really clear indication also to public health officials to make jurisdictionally appropriate decisions. We've seen Philadelphia, for example, make a decision that they thought was appropriate for them to go back to indoor masking. And I think you will probably see other jurisdictions view their local data in ways that enable them to make safe local decisions. And I think that's appropriate.
Sure, absolutely. Thank you. Dr. Montefiore, this is kind of a crystal ball question, I guess, but what's being asked is, obviously we're seeing occasional spikes here in cities. Do you expect, based on how the virus has behaved so far, that we could be in for another national surge at some point? Or is it more likely that we are going to see these pockets of outbreaks here and there that will hopefully be contained at local levels?
Yeah, that is a crystal ball question. I tend to think that because of all of the population immunity that we have now, we're not going to see a huge spike in especially hospitalizations and deaths that we've seen multiple times in the past, and that's a good thing. All of these variants that continue to emerge, it's very important to keep monitoring them. But there are always going to be new variants that emerge, and we can't get real excited, and well, I shouldn't say excited, real concerned about them every time. And we're really tuned in to looking at the statistics, which can cause a lot of anxiety. And we just have to get used to the fact that this virus is going to be with us for a long time, and it's going to continue to evolve. And unless it becomes more severe in terms of the disease that it causes, which is not what viruses tend to do, they, if anything, tend to evolve to become less severe. Not always, but most of the time. The biggest concern is that the virus will find a way to get around the immunity that exists right now, and that would create a real problem that would cause a lot of anxiety. But right now, I don't see that happening.
Gotcha, thank you. And Dr. Wolf, associated with that, if there were to be another national spike, or even in the meantime, as these things happen in cities, are you concerned that the removal of mandates and some of the public push against this will actually make it more difficult for people to get on board and mask up in their cities and communities if and when the need does arise?
Yeah, that's a really good question, Greg. And I saw that pop up in the chat, so I'm glad you raised it. I think yes is the simple answer. We've had, a rich history pre the pandemic of public health being a sort of a body that is cautious and is trusted. And I think we have seen many attempts to undermine that, frankly, in the last couple of years that have been difficult to witness. And the most recent change, I'll be honest, does worry me less about the impact immediately on flight safety. It worries me more about trust. It worries me about trust in public institutions, particularly at the CDC level, but frankly, this feeds down into local public health as well. And how we go about serving trust in our community to a population that seems increasingly, willing to not listen to good science and good public health. So, I think it's a real challenge moving forward. And actually, one of the biggest things that we should try and learn out of this is how do we communicate scientific information accurately? It's why we have these information sessions. How do we build trust back to say, we're all trying to aim for the same thing here? How do we allow leaders like the CDC to get back to a position that's trusted enough such that if we had to make a significant intervention with either another variant that became more severe, or frankly, the next emerging infection, of which there will be one, that the public in general has enough faith in the decision-making there and the scientific leadership to go, that makes sense, we should go ahead and do it for all of our sake. It's, there's a legal element to that clearly as well. I don't want to speak to the sort of precedent that got set by the recent decision-making, because I don't know its legal precedent, but I think the sort of public perception that national public health bodies make decisions that can be easily overturned, that's a really difficult perception that sits poorly with me. We know we've got to fund those. We know we've got to re-strengthen those institutions. If there's one lesson that comes out of the last 2 years, is that we need a lot of effort on that front.
Sure, absolutely. Thank you. We are just about at time here, and we are going to wrap up. And I'm just going to ask each of you one last question before we go down on the individual level, because that's where we are. Dr. Montefiore, you mentioned earlier that one of the most important things that people can do right now is to get boosted if they are not already. So I would ask you, if you were in a conversation with somebody who was on the fence about getting boosted and wasn't boosted, what might you say to that person right now?
I would encourage the person to get boosted. I would probably start out by asking them why they haven't been boosted and try to understand what the basis of their hesitancy is, and educate them if it's based on misinformation. Sometimes it's based on real concerns that they have. I had a personal case with a friend who had a serious reaction to their second vaccination and was very hesitant to get boosted. And that person also experienced a breakthrough infection that was symptomatic after their second vaccination. There are a lot of considerations when deciding whether or not to get boosted. The bottom line is that there's much better protection against Omicron. It's almost absolutely essential in most cases of people who haven't been vaccinated and infected to get that boost. We know how important it is to have really good efficacy, and in some cases any efficacy at all against serious illness and death. In the case of Omicron, it's important, and unless you have a really good reason not to get the boost, it's important to encourage people and educate them to how important that boost can really be to protect them and make them be able to go on with a normal life without fear of getting serious illness or possibly dying if they were to get infected with this virus.
Absolutely, thank you. And Dr. Wolf, I guess similar question to you, but on the lines of somebody that in this post-mask mandate world is going into a situation where they really should be masked. Perhaps they're symptomatic or positive, but is reluctant to mask. Is there anything after 2 years that you could say to that person, you think, to make them help them understand why it might be important to wear a mask?
I think if they're positive, it's a different conversation, because they should not only be in a mask, they probably shouldn't be in a crowded situation where I'm having to have that conversation with them. And that's still a clear guidance from every level. I think the question about masking in public spaces if you're symptomatic, it's always difficult. Like, no one wants to be the mask police, and that's where sometimes these rules are really helpful, just to get people all to a level. I try and at least let people know why I think it's crucial for them, because they don't know who around them may be higher risk than they perceive themselves. And I don't know that many people make decisions intentionally, selfishly. I think that's incredibly rare. And I think most times people actually, in my experience at least, have listened if you point out why that unique scenario requires them, or should afford them the chance to wear the mask. For example, in the hospital, we get that all the time. People who want to come in and hesitant or sometimes more belligerent, in fact, about wearing a mask in our space. And that requires a careful conversation about, this is a space with high-risk individuals. We don't want our patients or our staff to get sick because of where they are. And occasionally it rises to the level of saying, look, we don't want you on our campus if you're not going to wear the mask. But more often than not, actually, people are quite agreeable and say, look, hey, I understand that this is a unique situation and I'll put it back on. But it does require a little bit of education to say it's not just about that individual, it's about the people around them.
Absolutely. Thank you. Thank you both. We will call it there. Thank you, everyone, for joining us. Thanks to our panelists, David Montefiore and Cameron Wolf, for sharing your perspectives, as always. If you'd like to be notified of upcoming briefings, please email dukenews@duke.edu. In the meantime, please stay well, get boosted if you haven't been already, and just keep an eye on public health guidelines in your area. Thank you very much, and everybody have a great day.
Thanks, Greg. Thanks.